Thank you for having me. I hope next time I can see you all in person. In most places, and perhaps at your hospital too, this is what getting ready for surgery looks like, sitting around and worrying. When I interviewed 20 colorectal cancer patients and asked them how they prepared for surgery, that's exactly what they said to me. There's no preparation. I just sat at home and stressed. Now, these unprepared patients, they show up for surgery and they're hit with the surgical stress response. The surgical injury stimulates the release of counter-regulatory hormones and cytokines, and this leads to several metabolic changes, including whole body protein catabolism. Lean tissue, such as skeletal muscle tissue, is broken down. The amino acids are released into circulation and preferentially taken up by the liver. Why? Because the liver needs to synthesize glucose to maintain energy processes and synthesize proteins involved in the immune response and for wound healing. So essentially, the muscle tissue is sacrificed to fuel the important role of the liver. And now it's time to recover from surgery, and this is usually what recovery from surgery looks like, sitting around and waiting for recovery to happen. And this is particularly problematic for older adults because they're not usually hitting the gym to regain the muscle that they've lost from surgery. In this catabolic crisis model, the authors hypothesized that each time a catabolic event is endured, such as surgery or even as something as benign as bed rest, more and more muscle is lost until eventually our patients have lost physical function and can lose independence as well. So let's turn this traditional care model around with prehabilitation. With prehabilitation, we recognize that surgical recovery is not a passive process and that it begins before surgery. On the y-axis here, I have functional capacity, and the orange bar is the typical functional trajectory of a surgical patient. With prehabilitation, we aim to build functional capacity before surgery so that we have a buffer, we have this reserve in preparation for that impending surgical stress. Now, at the time of surgery, function drops, but we've attenuated this drop as compared to standard care, and the patient's able to get back to their normal function earlier, get back to their normal lives earlier. That's really the goal with prehabilitation. Now, how do we do this? How do we prepare our patients? We use multimodal prehabilitation. When patients come to see us, they're usually experiencing perturbations in protein metabolism that deplete skeletal muscle tissue. So for instance, they're sedentary, they might have tumor-related muscle catabolism, or an inflammatory response that's capturing up the protein that they eat. With multimodal prehabilitation, that includes exercise, includes nutrition, including protein supplementation if necessary, we aim to augment body protein reserve through promotion of muscle protein synthesis and enhance substrate utilization. So exercise is an anabolic stimulus, and nutrition provides the substrate to build body protein reserve. Exercise also encourages metabolic flexibility and insulin sensitivity, all important things to tolerate the surgical stress response. And the main goal, of course, is to enhance functional capacity so that we can mitigate losses in function after surgery. And here are our results. We have found when we evaluate recovery after surgery in terms of 6-minute walk tests, so evaluating functional recovery after surgery, if we don't do anything, we just give our patients enhanced recovery after surgery care, about 40% of our colorectal surgery patients have recovered their 6-minute walk test, have recovered their functional capacity by 8 weeks after surgery. If we give these patients a rehabilitation program, about 60% of these patients have recovered. And if we prehabilitate these patients, over 80% of them have recovered their functional walking capacity by 8 weeks after surgery. And we've found similar findings with fat-free mass. On the y-axis here, I have change in fat-free mass. Blue is prehab and orange is rehab. 4 weeks after surgery, you can see that both prehab and rehab groups have lost fat-free mass. And this is expected because surgical stress is catabolic. But by 8 weeks after surgery, we found that the rehab group continued to have a loss in fat-free mass, whereas the prehab group had a fat-free mass value that was very similar to their baseline value. So prehabilitation, it suggested, attenuated this loss in fat-free mass after surgery. And I want to remind you here that the rehab is not standard care. So I would expect the standard of care group to look that much worse. Now, who benefits most? We found that the patients who are slower at baseline. So when we do our 6-minute walk test at baseline, if patients can only accomplish about 400 meters in that 6 minutes or less, these are the patients that benefit most. They improve their functional capacity readily before surgery, and they recover their functional capacity 8 weeks after surgery really well in comparison to our patients who are relatively fit at baseline. And we've also, other researchers have also found that these high-risk patients are also more likely to experience improvements in their clinical outcomes, like postoperative complications. So I want to leave you with a little bit of an analogy. This is my dad's house in Nova Scotia. And there was a storm that hit the house and a tree fell into the house. And of course, you need to respond to bring this house back to its normal structure and function. This is very similar to the surgical stress response. When there's a surgical injury, it elicits a response to return the patient back to their normal structure and function. But what if my dad's house had looked like this? What if it was in poor shape to begin with? This is a much bigger response. It takes a lot more effort to get this house back to its normal structure and function. Will it ever get back to its normal structure and function? And this is very similar to the surgical patient who has a poor foundation to begin with. It will take a longer response to get that patient back to normal if we do it all. So with prehabilitation, we aim to strengthen the foundation so patients have an easier return to normal structure and function. If you want to learn more about prehabilitation, please check out our website, or you can always email me. Thank you for your attention.